curiosity why.
Mad Bricks webcast,
Where the human spirit flies. Mad Bricks webcast, where the human spirit flies.
Hey, welcome to the MedBix webcast. This is Ramana. Oh, my muted something. I don't know. Can you hear me? This is Ramana Namaraju. I'm the host of the MedBix webcast. Welcome to the MedBix webcast. Yeah, we have a very interesting guest today. That before I introduce the guest, let me introduce you. My co-host have a tagline for her. By the way, I wanted to tell you that my intro video it talks about few things. One is that the three people you show up on this one. I'm going to explain when Susan comes. Let me bring here Susan Davis. I have a tagline for her, and she loves it. Better looking, better talking, and brainy.
I'm
Welcome,
not sure.
Susan.
Good evening. I'm not sure I got a vote on that tagline, but happy to be back Thursday night live with you, Ramana.
Yeah, the 3 days continuous for nowadays. I want to tell you about that three people that involved in there. One is that the Dr. Richard Allen Williams. He's a founder of Association of Black Cardiologists. He went to the school in Harvard, first Harvard graduate of a graduate cardiologist from Harvard. He is the first one. And he is the founder of Association of Black Cardiologists. The second person, she is Dorothy Hodgkin. People don't know about her. She found the structures of the B12 and then even insulin structure. She found the actual structures. That's why you can design the drugs. So there's a Dorothy Hodgkin. I did a show on her actually. Dorothy Hodgkin. She was born in Africa. She's a British woman born in Africa, and then grew up in all over Africa and India. So she would travel quite a bit actually. Then she X-ray crystallography. That's one of the things how to find the live um, structures of the atoms and all those things. Then the third one is that my hometown gentleman. His name is is the same as my father's name, Dr. Yallapragada Subbarao. He was in 1923. He came to United States to Harvard, and then he was so good they hired him as the little Lidl laboratories hired him. He first came with the first antibiotic drug, automycin. He invented the automycin first. Then methotrexate, first cancer drug. So he was supposed to get a Nobel Prizes. They missed him. It was 1948. He died actually. That Pfizer acquired his lab after that. Very young age he died. But he's from my hometown with my father's name. We're all in the same thing. So that's what the three people in the pictures. Yeah.
Well,
But
I think for that, I gotta say, if you didn't know the history of all those amazing minds, then none of us would ever be blessed with it. I don't want to say never, but because you study them and because you know them so well and share them with us, I mean, that's really one of the reasons that I'm here with you, Ramana, because I love that education. You're keeping them alive. What amazing contributors.
we cannot forget the past, right? If you don't understand what their trials and triumphs, how can we do advance anything? We all advances are all fake in that sense. We know this exactly. Then you understand the trials triumphs they go through, why they did that. Now you understand the reasons and everything. It is a much more better picture there anyway anytime. So I
Historic.
always talk about past and I will bring to the present. That's what I
Yes.
do in my.
I love it's the historic wisdom that you bring up here to 2025 that is extremely enlightening. I love
Yeah,
it.
thank you. You're a great. You help me to move the things going on the right direction. Let us bring up one of the Jennifer Jaynes. So she's from Ohio. She's joining from Ohio. She is a operational experience in operations, right, Jennifer? When she has a lot of implementation of a lot of these systems she did, and then she worked in the complex. Very economically challenged population. She was working with them and then implementing them. And then, that I always believe health is a human right, doesn't matter wherever you're in the world, in the entire world. I feel that health, we need to provide that. However complex it is, we have to provide that. That is a first and foremost right. If you cannot do that, that we are not a human. We are not doing right things. So
That's
that's why I wanted to put Susan's
our mission.
AEDs everywhere in the world. Save
It
the people.
is,
Okay,
Jennifer.
Jennifer, just you explain to us a little bit of your background. I didn't say a lot of things, but you tell us a little bit your journey from beginning of your healthcare career.
Absolutely. Well, first of all, thank you for having me on the podcast tonight. I feel very honored knowing others I admire in the healthcare industry have participated also in this podcast. So thank you again. I'm honored. So who am I? My name is Jennifer Jaynes, and I basically have spent the last 20 years working in the intersection of healthcare operations, public health, and more recently, virtual care. The foundation of my education and the love for serving others has been strongly based on the public health principles. I hold a master's in public health and a minor in psychology. Clinically, I am a certified diabetes educator. But I chose the public health realm simply because public health to me is medicine for the masses. And I felt that training in public health would allow me to reach more people than just one patient at a time. So, fortunately, my path has taken me to the front lines of public health and to executive space that occupies like multi-health rollouts, including large behavioral health projects that serve cohorts that are considered vulnerable populations or complex populations. I cherish really working on evidence-based, clinically effective programs that highlight measurable outcomes and focus on ROI. And my my operational strategy and why I love what I do is ultimately to improve patient outcomes, whether it's reducing admissions or building scalable models of care. And honestly, I could go on for hours talking about my work, but that's a little bit of what I am and and what I've done. And of course, it scales more than 20 years. So
Let me ask you first question, and then I'll let Susan follow that up. You know that during the pandemic, every weak in the system, every weakness in the system is exposed. Your logistical supplies were lacking. Even California, they don't have enough masks. So all kinds of things. The ventilators are all shortage. And then on the top of it, the economically disadvantaged population, they is a when you need a ibuterol or a ventilators, and the shortage of the what is that called, CO2, the oxygen saturation, pulse oximeters. We're running out of all of them. That is the pandemic gave us experience of what is going on in a national level. So tell us your experience of the pandemic experience, how you navigated this telehealth care, and then one of the solutions is telehealth care, telemedicine. How did you navigate, and how did you put together the whole process with the operations side?
So during the pandemic, as we know, it was a very odd time in healthcare. I was working at a major health system in Dallas, running some auxiliary clinics. And in the sense that I felt it was very unusual, simply because there was somewhat of a disconnect between what is public health, how does public health ensure the safety of large groups of people versus how do we address treating one person at a time. And those two pieces intersected and were a little bit dysfunctional. And basically that was the empowerment of telemedicine. I think that was the crux, where telemedicine changed. Obviously, with the expansion of telemedicine in clinics and hospitals, simply because people were not allowed to leave or venture into different spaces, the development of virtual care was already there through different systems like Teledoc, but it really became prominent and pushed through barriers that were not known or seen or understood before, where hospitals were so desperate to serve people, but were so overwhelmed at the same time. That's where telemedicine took a turn. And through different channels of government and different opportunities that arose, that was kind of the rise of virtual care, virtual health as you know it today. And it has definitely assisted in the expansion of telemedicine.
So there's been quite, I mean, I'm just trying to follow the journey in my mind, because I'm thinking way back in the day, you know, when we had teledoc, we had, you know, you were having a stroke, and now we have a neurologist that we can pop into the room. So it seems like telehealth was really a big deal, you know, a decade ago, one doc on a screen. And then, yes, the pandemic and the scramble. And now, then it seems like at the same time, simultaneously, we're growing the amount and variety of what can we offer through telemedicine, both in the acute care setting, in the outpatient or clinical setting, and now the big trend is the hospital at home. So is that, did I say that correctly? Does that sound like a normal progression, or what would be the trends you would say? Was that a trend, and where do you think we're going? Is that where we're going? Are we going home?
Yeah, I think there are programs that are organized through the home. I think that's based on the needs of the person. We look at the social determinants of health, and we understand that everybody has different needs. Not everybody has transportation to make it to their doctor's appointment. Not everyone, as I mentioned, I deal with predominantly a lot of complex or vulnerable populations. In those particular cohorts or populations, they don't have the same mechanisms that, say, the majority of the populations experience. You know, maybe they don't own a car, or maybe they live on disability, or there's a lot of different areas that encourage or discourage them being able to see their provider. So this is the beauty of telehealth and virtual health, is that they can expand that. I read a study once that stated it was like some ridiculous, really high amount, like 90% or 98% of the population owns a cell phone, not just like the old flip phone, but a smartphone. So knowing that you can access your provider through your cell phone is simply amazing. That's something that 15, 20 years ago, we would have never thought as possible. So I think the expansion of technology lends to the expansion of virtual health opportunities for those people who are not necessarily in a space where they can access opportunities for better health.
Yeah, and you touched on right where my next question was going, was the technology. So when you start looking at critical access and rural communities, that's a big access. I mean, Romana, comes up in every one of our conversations, is access to care, access to care. So this is the answer, right? I mean, this seems to be the hot answer.
Absolutely. Yeah, absolutely. Predominantly a lot of the work that we do or a lot of work that I work in it does reach those rural areas. And those are the areas that maybe can't afford a neurologist or can't afford an infectious disease provider. So the beauty of telemedicine offers, and think about it, it reduces transfers. It's the number one thing the hospital is really wanting to absorb, is they want those bed stays. So it really is such a fantastic tool to patients as well as providers, because they're able to reach more patients, and they can be like Romana in California, and their patients are in Ohio. So it's fantastic.
Jennifer, that's a very point that I attended last week, Stanford medicine. You know, one of the speakers was wonderful in that sense. He said that all these AI doesn't mean anything. Only way, if it works in a rural population or vulnerable population, you have to demand, not in the Stanford big Ivy League school in the four walls of all the Palo Alto is the richest center, richest place in the world. Not in this one works here. You have to make it work in those places. Do you agree that is a situation where we need to demonstrate that AI and all the new technologies to work in those vulnerable population, work in those rural areas?
AI is a interesting tool. I would love to see where this expands to. I think in rural hospitals, I think in any hospital, telemedicine is very useful and effective to reach patients. In terms of I believe that AI is being used or can be used to entertain a lot of different measures, as well as it helps the hospital, specifically, it's helping the hospital understand like how we can become more efficient in either med recs or you know, there is a modality that's out there that will test your pulse by just sitting in the bed, blood pressure. It's very fascinating tools, and it encompasses a room. So whatever, and there's a nurse that monitors this at a station outside generally at the nurse's station, but it can monitor all the vitals of a patient without even stepping into a room. So I think there's some challenges in understanding AI, but I think ultimately the future of AI is what it used to be for virtual care several years ago. I think the expansion of it is only going to bring great opportunity to reaching patients that we weren't maybe able to reach before, or in fact, help us understand early onset of disease or a diagnosis. So I think it's wonderful, but it has to extend into the rural areas, not just the big cities.
Susan, I just wanted to ask you, she's a nurse, she can tell more about these kind of things. If you put all these places, all these, just after that, let you talk, Susan, that if you give all these, one of the areas that they want to demonstrate is the data that is coming from all these the wearables, remote patient monitoring, all the variables coming. There's a lots of bathroom data, there's a nonsense data. There is nobody at the time to process this data, but then Susan doesn't have time for all this, looking at a kid, keeps sitting all these people sending all this data. So there is an AI should summarize the whole thing. Hey Susan, this is the danger, this is the one patient is a problem. I think that I see, let Susan talk. And yeah, go ahead, Susan.
No, but that's a perfect example of where AI would come in. I mean, if it's going to be taking in massive amounts of data, that's what everyone's loving about AI. I mean, nobody has the time to go through massive amounts of data, and these humans would likely to miss some patterns, very fine patterns. A lot of people, especially with cardiac, it's something that comes and goes, and then it's like the trick that your child does, and when you get in front of the crowd, they don't do it anymore. But AI can pick up on that. I'll tell you, one of the concerns that I have, with what I work with, cardiac arrest training, emergency response, with this movement towards telehealth, we can use like radiology as an example. We have a telehealth radiologist, and now we have remote technologists, and now you've got a patient in a room getting scanned. But let's say there was an emergency, let's say there was an adverse event to a contrast media or any other drug. Who's in the room? I mean, doesn't the training, for me, it's always training and education. But what do you see that as problematic when we have, people on screens, but the people who are there in the space have to be prepared to handle the patient with the hands-on care?
Absolutely. I think under those circumstances, what's needed to remember is, you always need a human to manage an AI process, right? All workflows still have to account for code teams. You still have to have teams that respond to code. So if you do have an adverse event, what does your workflow look like? How quickly can you call that code, and how quickly is that team going to get there? Those staples of nursing, of medicine, have to be in place, and you have to understand that AI is not going to replace human it may replace human in the process of taking all that data in and assimilating it quickly, but medicine is still you still need the human touch, and in hospitals and in clinics, I think it's a supplement to the human touch. So I don't think it's ever going to go away.
No. But to your point, so I mean, I love it. Again, data, like Romana brought up. So early warning. There's so many. We have multiple patients, but even in the clinical setting, they're tasking. We've got patient care coming and going. So I love the idea of the early warning systems of AI taking down all the vitals and or whatever else we can feed it. There's backside parameters that may be coming through too. It might be able to consider lab work, a recent neurology exam. If it's all talking to the EHRs are talking. So, and then in your expertise, in your area of clinical, we were talking about this before the show. I don't usually know I'm learning the lingo between clinic, outpatient, ambulatory care. But there could be, they don't have go teams out there. They call 911. They've got an AED and they call 911. So I'm interested in the training to be on a telehealth team. Is there education? There must be, obviously, but is there robust education involved for being prepared to be on one side of the camera versus there with the patient?
Excellent question.
Absolutely. Yeah, absolutely. So generally, I would say that you need to be a medical doctor to diagnose. So on one side, who is observing or consulting on a patient, they're usually medical doctor, board approved, and privileged at that particular hospital. On the backside of it, you have the patient, but you will also have a nurse or a clinical specialist that's there to assist, because there are circumstances that evolve where a patient could code, or a patient there's symptoms that are seen in the middle of a consult where someone might seize. So, I think that ultimately, in understanding whether it's on an ambulatory or a clinic setting or in an acute setting in the hospital, there is a workflow that has to be addressed, and that workflow has to maintain a standard of what is medically acceptable, but also what fits the designation of the staff that's providing the care. So it's not always going to be the same. I would say that what workflow works in neurology is not going to work in cardiology, and what works in a clinic is definitely not what's going to work on inpatient. So it comes down to understanding how the specific sites work, what's their process, and how is telemedicine going to make their program successful. So it's looking at all the aspects of
Let us move to the different subject a little bit. It's called value-based care. This is so many definitions. I started with the value-based care in the beginning in 1990s. They have Medicare plans and Medicare Advantage plans and all these things. Some worked, some didn't work. This is a really challenging. Tell us a little bit about value-based care. Where, for example, I give you one example of account care organizations. It did work, but there's a problems there. One of them is liability issue, and then they're not doing enough tests because to save money. All this, lot of dynamics there in the value-based care. What is your opinion on the value-based care and how it should be implemented? You're expert in science of implementation. So tell us a little bit about that.
So with value-based care, I think you're looking at 4 key components. One would be care coordination, like how proactive is the management of like high-risk patients, and how seamless is the transition of care, for one. 2 would be data-driven insights, like risk stratification or predictive analytics, or maybe even being able to implement like real-time dashboards that target specific interventions. And I think the third might be, well, your HEDIS metrics or your star ratings. What are your cost benchmarks or your quality metrics that need to be met for value-based care? And then, of course, you're always going to have patient engagement, right? Who's sharing the decision making in that? Does it involve remote monitoring? Does it involve like health literacy support? So there's a lot of pieces of components of value-based care if you're looking at the larger realm of it. You can also, I would say this, the beauty of value-based care is you can reduce avoidable utilizations, like lower those ED visits, because we all know that's an issue, or readmissions. The 30-day readmission mark from the emergency side is always a stickler. I think it can assist in chronic disease management. You can utilize value-based care to improve A1C control for a diabetic, or blood pressure management, or even adherence for at-risk, like high-risk patients. I think also there's a behavioral health integration piece too. You're able to address mental health needs, and addressing those will improve outcomes and ultimately reduce total cost.
I think
there's a lot
those were excellent real life examples. You went from the business, standpoint right down to the reality of the bedside. And I love taking concepts in this show from where we are when we're talking big picture business, and then bringing it right down to the bedside to the people. So those were great examples. And then you did say something about reducing ED visits, which I read something in something that you worked on previously, and I'm going to kind of bring this there. I believe some of your work reduced visits to the ED by 10%. And then it was something like it was at the same time it was police involvement with mental health cases, which is huge. My background is an emergency room nurse, trauma nurse, and so that was a major part of our days, having mental health patients, behavioral health patients in the emergency room really take up bed space, and they need lots of care. And to reduce 10%, that was big. Tell us about that.
So, well, there's two parts to it. The first part is I've worked with several hospitals around the Dallas County area, predominantly to look at reducing those ER visits and discharges. Those 30-day, ones that come back after 30 days because they don't know what to do. So worked with several hospitals there. But primarily, the largest increase in, how we lower the utilizations of the emergency rooms and incarcerations. I worked on a project. I was the director of a project in Dallas County, and it involved looking at a larger cohort of, well, I shouldn't say larger, but it was a cohort of about 50 people at a time, and we housed them. We used the housing method where we would house them and give wraparound services. So not only mental health services, but medical services. So we engaged with the county jails where there was high levels of incarcerations. With the county hospital, Parkland Hospital, where there were a lot of homeless or people who experienced homeless, were engaging in emergency room visits because they needed a place to sleep or they needed a warm dinner. Also, we looked at those individuals who the county just had a really rough time. They couldn't keep putting them in the state hospital system and getting viable outcomes for their sustainability. So we looked at how can we engage with the local mental health systems to increase their engagement with mental health providers, but also look at lowering their hospital stays, their incarcerations, and the cohort of patients that we served also had high incidence rates of chronic disease and or some kind of substance abuse. But they were also chronically homeless, which generally means that they have a substance abuse issue as well as experiencing homelessness. And so it is kind of like that vicious cycle that just keeps them down. So within this cohort, we're able to bring multiple layers of services together. On top of that, we were able to provide housing and food and stability for them. And then in turn, we had a partnership of my team that worked with them day in and day out. Not only, I wouldn't say to like normalize their lives, but just bring them to the point where we can understand what was their baseline, where do they want to be. We actually had really amazing outcomes, not only the ones that you mentioned, Susan, but we were able to so-called graduate our neighbors, as we call them, to graduating from high school, getting their GED, going back to college, gaining a career like in real estate, or getting married and moving out on their own. So there's a lot of pieces of that. It's not just looking at the bottom line ROI as to how much can we save taxpayer dollars or how much can we save the hospital. It's really about what's best for the patient. And sometimes going to the hospital is important. Going to the emergency room for the right reason is important. Getting those issues that are plaguing you so that you can have a normal existence again means having a team that can lift you up as a patient, but also be there to have a shoulder to cry on, because they have really rock bottom days, those people in those types of situations. And also engaging with those different entities, the hospital, the court system, the police department, with local judges, and having them look at policies and maybe, do we have to change something? Do those people in the cohort get arrested too much because it's really hard for them to stop hanging out on the corner and panhandling, because that's what they've known for 10 years. And instead, we give them a life. We gave them opportunity to reach out and maybe stop overutilizing some of those services.
Bravo, Jaynes. Bravo. That is awesome. We need more of you. This is a clone situation.
I'm so glad.
Every county and everywhere needs exactly what you just described. It's such a major part of our world and our humans and our people and our neighbors, as you so eloquently described them. Fantastic work. And I think often that many of these services, we know that there's many services in an area, but if we don't come together and dump them all on the table and see what we're all doing, and then share in that project like you just described, we can do this. We can get them graduated from high school, get them married and graduate them and help them and move on. But there are dark days, and when everyone just, we're burnt out, then we still have this is a situation that's not very human.
By profession, I'm a physicist. That whether you look at the quantum physics of the process or you look at the healthcare, both of them end in two things: love and compassion. That is where they end up, in the love and compassion side. That's the two things that they end up. I think that is you're the exemplifying that whole process, as Susan said, is really truly we need people. There is no reason to be people suffering with all the resources we have. It's just there's no excuse or reason for people suffering.
But I can tell you what you need is a chaos specialist. Jennifer Jaynes, self-proclaimed chaos to clarity rock star. So I'm on Jennifer Jaynes' team. I've got your back. So I hope this project is
Thank you.
Pick me. That's really good work.
I'm going to let
Yeah.
me take you a little bit, but I will when I come back. Will ask you about the implementation science. How do you deal with the doctors and nurses? When the nurses say that, hey, implementation specialists are coming, they want to run away. Right? They don't want to be around it. So I want to know how you deal with them. This
Me
whole
too.
gang. Before that, I'm going to present a topic. You're going to like it. Let me do that. Can you bring us the my yeah, very good. This is a Jennifer Jaynes. She's coming from Ohio. She's really um, doing there's a small one, yeah. There's a really doing a great work actually. Okay, let us talk about scrubs and suits. So that's what I'm going to talk about. How the implementation specialists they scare the doctors and nurses. But I'm going to talk something before something there. Exponents. Okay, this is a very let me deviate for something different, and then you'll understand why I'm talking about this. Your grandmother, this is a case, and I give an example of that. I give you call the grandkids and say, I give you $1 per day for the next 30 days. Okay. Or I give you a penny for the day. Next day I'll give you 2 pennies. Third day you get a 4 penny. Third day you get a 8 cents. On fourth day you get 8 cents. Just double the number. Which one you take it? She will show you a dollar bill and then penny on the right side. Which one? What the kids will take? They take which one they choose. Choose only one. You know what they're going to choose? Choose always one. Option one they choose. But let me tell you,
Mhm.
thank God they didn't choose option two. Let me tell you, her, her entire retired savings she has to spend if she does. I give you a penny. That is their $5.4 million. It will go into the 29th day. It becomes a $5.4 million. Do the chat GPT if you have questions. Do the math up there. $5.4 million. And the day one is called exponential. It catches up all of a sudden at the certain after a certain number. We don't know. So that's why I tell you why it catches up like that. Day 60, you cannot even fathom pennies, doubling the pennies. $6 trillion every year, next 2,000 years, she has to give. Our brain doesn't fit. It doesn't make any sense. If
Definitely
you
not.
want, so I made a AI of Susan. She's
Oh my
wearing
God.
the clothes. Hey, you need to get pillows, Susan. you know, I tell you, this is a simple thing that you go to a party and come back and you throw the pearls in the jewelry box. The way it falls in the pattern. If you want to get the same pattern, you know how long it takes. Every day you do, million years are not enough. Exact pattern. This is the strangest phenomenon in physics. Million years you will not is enough. There is no computers can compute this process. So even if you take a crumpled paper, if you do origami, I know the steps. But if you have a crumpled paper, how many ways you can crumple the paper? There is no computation. There is no computer can do that many ways. It is impossible. Billions of ways is can crumple. So it is a beyond a simple play can cause huge complexity. So why? Our brains evolved in a linear world. We only think about next day, tomorrow, day after tomorrow. We don't think that much far. Early stages feel slow. Late stages overwhelming for us. We don't think that's the way the human mind was. Our neurons were structured. Limited exposure in daily life. We don't have a exponential curves in the daily life. We don't have that. Optimism bias. We underestimate. Um, we overestimate the positive things and underestimate negative things. This is a complexity. We underestimate complexity. That is where the hospitals and everything. I'm going to give you hospital system, a scheduling problem. If you have 500 employees, you have three shifts. If you give all the choices, okay, you see the mathematical problem. 3 to the power of 90, 3 quintillion choice. All the 500 people, you want to put a scheduling all the schedules available. 3 to the power of 90, which is 3 quintillion. You know how many it takes years there? A computer to compute that? 1,000 years. You not even come close.
Wow.
So the staff scheduling is one of the most complex things. A lot of people don't know that. Nurse scheduling, we put a lot of restraints. The departments will break them up, and then 3 shifts and all these things, but it's still complex. Because everybody has a different needs and different things. So this is a balancing patient needs. Another thing is, as we were talking about, Jennifer, that's one of the biggest tasks. It's not easy because patient needs are so varied, right? There's a wide spectrum. Staff utilization, how do you allocate which one is the more important? MRI center, the MRI there. Where do you want to put a scan first, or who is going to get the scan first? Resource
Mhm.
allocation, that's a very important. Staff allocation, resource allocation, and pricing, how they can afford. Is it possible? Insurance company is paying or not? Reimbursements are there. All these complex structure. This is a complexity. It's a beyond computer computation. In fact, hospital exponential staffing shortages, increased regulation reporting, technological advancement. This is called software entropy, hospital entropy. They call. Whoa, out of chaos. Susan is talking about chaos. This is a chaos theory. It's just out of this our comprehension. That is what the management comes in the picture. So what so then there is explosion of data, right? Medical imaging, wearables, pricing, all this data hospitals cannot handle. There's no way you can handle. There no computers can handle that. But there is kind of a solution, but it's not there yet. These computers are beyond the computational capabilities. No computers can do. These are thousands of years it takes to compute. Okay, so we don't understand it how long it takes to do a simple scheduling. So you need a only way to solve the problem is the quantum computers and AI. You need a real workhorses, the new kind of technology you need. Quantum computers are, there's a new way they work together, then a strange way. I will just explain to you a little bit about that. So Cleveland Clinic, where you're in Ohio, they are implementing now patient scheduling optimization through quantum computers.
Hmm.
Yeah, Cleveland Clinic got the first one, got the quantum computer. Their IBM installed it there. They are using a patient scheduling optimization before the patient. It itself is a huge task. You need a quantum computer means you need beyond our universe. We are bringing from other universes the computational resources. So that is so what is a quantum computer? I'm just going to give you a little bit of if you have a cheese in the back in the side, then quantum the classical computer what it does, it goes to the all the mouse what you keep on trying each wall, hits the wall, come back and keep trying. Eventually, series of steps, it will find the cheese. In the quantum computer, they do something strange. We don't even know understand everything about it. It becomes a ghost. These mice becomes a ghost, thousands of ghosts, and travel all together at the same time, and then find the possible shortest path, and then come back in time and go and fix that path. That's what the quantum computer is a general description I'm giving. It's not, So that is what the quantum computer essence of quantum computer is in that sense. That's where the classical. So you know why these guys are rich? All these guys, the Mark Zuckerberg, is the Jeff Bezos, and then the Tesla guy, Elon Musk. You know why they have an exponential mindset. They understand the exponential process. I will explain to you what that exponential process is. Very strange mindset you got to have. This is a Peter Demandis, another guy who gives there's a lot of this kind of a mindset. How do you have a mindset this to do this? I can give you the one example of Susan's example. For example, I can give you. It's called MSP. That's what he calls. MTP. I think MTP. What is a massive targets a problem opportunity with a global or industry wide impact. So what is Susan is trying to solve is a heart problem, the cardiac problem. They wanted to sudden death. She wants to do that's a huge problem in the world. people should not die in drop dead because of there is no resource there. That is a massive problem. How do you transformative? Aims to fundamentally change the way things are done. You can't use, okay, tell me what your needs are. That's you need to have a new mechanism, new kind of things to implement this kind of process. Global side, how do you implement automatically without you being there? Your process is implemented everywhere. That's a transformative process. Okay, this is the exponential mindset. That's what I'm saying. Purpose driven inspires teams and stakeholders and communities. Jennifer is doing inspiring communities and taking care of them. You need to be, you're not involved with just the medical community. You have to involve all the stakeholders. You type one place and then repeat copy that automatically it copies everywhere. So
Mhm.
that is a exponential thinking, exponential mindset. One of the most important is that networking, collaboration. Me and Susan are collaborating on this podcast. It gives enriches our ideas. Collaboration is extremely important because not like before. I want to do on my own. I want to be, that the Mark Zuckerberg does this. Those days are gone. That's when everything is not there. Now you need to have a network and need to have a collaboration. All of them are very vital to the exponential thinking. So exponential thinking is, we can't solve all the problems. That is impossible. These are all exponential. No computer can solve it. But you can go in that path with that mindset. You will grow big time. Not only in business, this is you can apply in the that is what the philosopher I'm coming. Use technology tools, meditation, or you can do self improvement. Use technology to do your improving your knowledge and everything. Network and collaboration, very important. Networking nowadays, you cannot sit down at home and then do all these kids are doing. That's going to be a problem. Leverage small actions, do the micro actions and improve. And don't double, expect 10 times your results. That is the massive transformation. That is called exponential thinking. So so it is not a suits against scrubs. There is no science with the people. You need to understand science. You need to understand the complexity. There's a problem there. This is a it's right in front of you, so obvious, but it can get so complex. What you're doing in hospital or whatever we do, it can complexity seeps in. That's why I always talk about that subject called entropy. The concept, the complex stuff seeps in without your knowledge. Okay, so that is what you need to worry about. That's why you need to have an exponential mindset. If you have exponential mindset, you can go, there is no places can stop. Okay, so that is, if you have time I would have played another video, but let me bring all of you guys back. Yeah.
Bravo, bravo. I love
Yeah.
another second round of applause during this show. So
Yeah, thank you.
say, Jennifer, that the reason Ramon and I have become such good friends over the last couple of years is because of the way he teaches and those amazing concepts. And I couldn't help but think that everybody, the three of us on the stage, all have exponential minds, and we think exponentially. You cannot be a public health person and think about one person, right? You're thinking about the word population. The definition
Yeah.
of the word population means masses.
Exactly.
And so in order to serve the
Yes.
masses, you need exponential thinking. You need every one of those steps. So what'd you think?
It's fantastic. It's my mindset 24/7. I call it the global
Same.
the global mindset. I honestly, yours is way more elegant than global mindset, but I truly believe that in order to solve any problem these days, it does require a global mindset, because the problems of today are very complex and they are very unusual. Go back in history. You mentioned, Ramana, go back into history and look at what happened 20 years ago, what happened 10 years ago. We didn't have the same problem. So as the complexities of the world get odder and stranger, we need to keep an open mind as to the best ways to solve them. And sometimes it's easy to get stuck in what we do, right? It's the same
Yeah.
thing. It's easy. We don't want to change it. But it definitely takes the right kind of leadership to understand that you cannot stick with the status quo all the time. You will never grow, and your business will never improve
Yeah.
the way it should,
And
right? To its highest.
so this is where the implementation science comes in. Okay, the hard part. We can be altruistic all we want. We can solve the world's problems, these complex problems, but there is implementation of these solutions, and that's the tough part. And so now we take an exponential thinker such as yourself, and I love that you are you've studied implementation science. I actually studied implementation science in my doctoral work as well, and so fascinated by it. And I'd love to get your take on, or any implementation in general, science, maybe something you're working on right now. But man, change is not an easy flow for the non-exponential thinker, which is a lot of people. Or am I
Correct. And
assuming that?
no, you're absolutely correct. And this is, I know we spoke about this earlier, but this is where I love Six Sigma, right, in healthcare, because Six Sigma allows us to like turn clinical excellence into repeatable, reliable results. Like that's the beauty of it. And that's what we want in healthcare. We want that stability so that we can translate that to not just one patient or two patients, but every patient. And unfortunately, in healthcare, variation is the enemy, right? And Six Sigma, definitely following that methodology, it helps us fight those variations. Would you like to go down that road?
Let me. This is a very important point you made. I wanted to, you mentioned, this is the way three steps has to be done. Philosophy of care. We need to. What is the philosophy of care? Well, there is reduce suffering and take care of the people who are sick. All those. That is a philosophy. Then second one is the methodology, the mathematical algorithms and all those things come in the second. Third one is the technology. You don't start with the technology, that's like Epic is starting. That's a problem we have. Okay. They're trying to
Yeah.
impose those kind of things. That's always create a conflict, right? Tell us implementation, what kind of conflicts you face.
Good.
I don't want to put you in trouble with Epic guys.
Be here till next week.
I know, right? Well, I will say, as it relates to virtual health or implementing virtual health, I'll be honest with you. It's the pushback, the human pushback. There are a lot of brilliant minds out there, but the mindset is that the patient only needs them, that particular mindset or that particular person. And so it's interesting. The hardest portion of implementation is the buy-in from leaders in the hospital leadership, medical leadership. Usually executive leadership's a little bit easier to understand and move it forward with, but medical leadership isn't always happy with that methodology of virtual health. And so and basically there's several pieces that you have to work with. Gaining the trust of that individual, knowing that the workflows that we're presenting are viable to them, and maintain the same standard that they would maintain. One of the ways we get around this is having the leaders meet and talk about, what's your biggest fear? How can we be successful? What does that mean to you? And how can we get around that? And how can we show that we can be just as important as your on-site team is? And how can let us show you how we can serve your patients when you're not there? And that's one of the biggest worries. And so I think that there is a system level approach that we have to address, but then also there's that huge trust factor that if that is there, it makes our jobs a little bit more difficult. But ultimately, through lines of open communication and meeting with peers who understand the challenges and have worked in that space for so long, it makes the transition a little bit easier for them, and they're a little bit more open to understanding that maybe this will work. Let's try it. So usually we can win them over simply because we have such fascinating, intelligent people working with us on our team. But often that is it's fear. I think it's fear-based that pulls you away from that.
Quick comment
opportunity.
before we close. Quick comment from Susan. Yeah.
Oh, wait, I don't know if I have so many things to ask, but you mentioned the trust factor. So let's just quickly close with the trust factor of the patients. Is there in 2025, are they trusting this service? And is there a generation that's trusting it more than others and others maybe not so much?
Yeah.
I would say for the most part, most people are open to it. I think with the rise of technology, the use of cell phones, the use of personal computers or iPads, I think, and FaceTime and Zoom and all these teams, all these opportunities, I think people are a little bit more open. I think also it's maintaining privacy for that patient. I think it's very helpful to have another clinician in the room with that patient when the virtual visit is being established, because then they can ask questions. They don't know this person behind this, on the other side of the camera or on the TV screen, but they are definitely, most patients are open to it. And there's a thing called informed consent, right? So they are asked if they are okay with this. So if that's not being presented, then obviously there's another means that has to be attended to. But the patient always has the opportunity to say yes or say no.
I love closing with that. That's excellent.
Jennifer, that is a compassionate science you're using. I love you for that. You're truly a personification of compassionate science. We need that heart, the compassion, and then you have to use science. Both of them are powerful. For me, you touch in my father. It reminds me, my father was providing a care for people who are poverty stricken in India at the time, 1960s. He was providing a care for them. It really touches me that inspired me to do all these things. Thank you so much for joining with us. It's truly an honor and a privilege to have you.
Thank you so much. It was my honor.
Thank you so much. Thank you, Susan. Everybody. Good night, all of you.
Thanks,
One
Susan.
exponential finger to another. Good night.
Yeah.
That's right. Take care.
Yeah, let me.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.